Hey guys, this presentation includes research provided by Jenna Shear, Christian Thomas, and Danny Blassen. Throughout this presentation, our goal is to educate you on the pharmacokinetics and dynamics of a new drug that has found its way into the marketplace. Our hope is to use studies to compare this drug to other sedatives that are used more commonly to increase the comfort of its use and aid in its safe administration. The drug may sound familiar to other drug classes, but it carries a unique drug profile. So, let's get started on learning about Remimazolam. Some basic background information on Remimazolam, also known as Byfavo, is it is a benzodiazepine and a derivative of midazolam, a drug everyone uses on a daily basis. However, it carries its own unique molecular structure. This medication became first approved in Japan in 2020 for general sedation, but still has not cracked the surface globally and is only approved by the FDA for procedural sedation in the United States. Remimazolam may take some time to gain popularity as it is still very expensive and no generic versions of Byfavo exist at the moment. To compare, it is roughly 5 to 10 times the cost of similar sedatives. Alright, on to pharmacodynamics and pharmacokinetics. Remimazolam's unique molecular structure features a carboxylic ester linkage that allows for rapid metabolism into inactive metabolites. This makes remimazolam preferable as its ester linkage allows for a rapid offset. Its ester linkage is metabolized by tissue esterases, primarily liver carboxyl esterases. This does mean that in the setting of severe hepatic failure, its metabolism and clearance may be prolonged, making severe hepatic failure a relative contraindication. Remimazolam is cleared in the urine and is protein-bound mostly by albumin. Its effects are consistent across age groups and is still a successful sedative for patients with end-stage renal disease and mild to moderate hepatic failure. For its mechanism of action and clinical profile, remimazolam, like many other sedatives, acts on the GABA receptor, specifically the alpha subunit, hyperpolarizing cellular membranes by increasing the influx of chloride to achieve its sedative effects by enhancing the inhibitory GABA receptor. Dosing is initially recommended at 2.5 to 5 milligrams over 1 minute, followed by additional doses of 1.25 to 2.5 milligrams as needed dependent on the patient's ASA status, and this is for procedural sedation as what is approved by the FDA in the United States. Remimazolam displays a rapid on and off drug profile with its onset in about 1 minute and its peak at about 3 minutes. Patients rapidly metabolize remimazolam and are fully alert within 10 to 15 minutes after the last administration. All sedatives come with a safety profiles to be aware of when administering these medications, and remimazolam's most frequent side effects is hypotension, which was displayed in 37% of patients in a 630-person study amongst ASA 1 through 4 standard patients. When discussing important considerations when using remimazolam, there are several in order to safely prepare and administer it. There is only one absolute contraindication, which is for patients with an allergy to dextran 40, an ingredient in the medication. Its metabolism and elimination is rapid, however, it can still be reversed by flumazenil, which may be most pertinent in patients with severe hepatic failure. As compared to other sedatives, its use is synergistic and should be cautioned when used in adjunct with opioid analgesics as well as other CNS depressants, as this can cause profound sedation, respiratory depression, and even death. When considering remimazolam's use in special populations, it is not yet established in patients under the age of 18, and its use in the pregnant population can cause neonatal sedation or withdrawal symptoms if administered late in pregnancy prior to delivery. Remimazolam does come in a powder form and requires reconstitution with normal saline. Reconstitution with LR may cause crystallization. Alright, let's get on to some clinical studies and compare remimazolam and propofol. One being performed by Gao et al. On patients undergoing carotid endarterectomy. The study showed there was no significant difference maintaining cerebral blood flow. However, remimazolam did achieve higher MAP scores, meaning less hypotension, prior to intubation compared to propofol. Another study comparing remimazolam and propofol, performed by Liu K et al. For patients undergoing endoscopy procedures, showed the hypotension rates amongst remimazolam was 36.5% for remimazolam and 68.6% for propofol in a population of 400 patients, ranging from the age of 65 to 85. In additional studies comparing remimazolam to propofol when examining the consistency of emergence delirium was performed by Duan et al. 60 patients undergoing hip replacements were induced for general anesthesia with either remimazolam or propofol. In 10% of the patients receiving remimazolam, emergence delirium was displayed, whereas 33% of patients who received propofol displayed emergence delirium. The study also strengthened the hemodynamic stability of remimazolam compared to propofol that previous studies that were discussed had confirmed. In a study performed by Nicholas Pastis et al., the use of another benzodiazepine, midazolam, was comparatively studied to the use of remimazolam in 446 patients undergoing bronchoscopy. The time to complete bronchoscopy procedure was found to be shorter in the group receiving remimazolam, and also required less rescue sedatives to be given throughout the procedure, as well as a lower overall dose of fentanyl were needed compared to midazolam. In a study performed by Hugh et al., the use of etomidate was comparatively studied to the use of remimazolam. Etomidate is a known and well-studied sedative that produces less hypotension and more cardiostability compared to propofol. In this study, 117 patients undergoing cardiac valve replacement surgery were divided amongst a low-dose remimazolam group, which was at 0.2 mg per kg, and a high-dose remimazolam group, which is at 0.3 mg per kg, and a group given etomidate. These sedatives were given upon induction of anesthesia, and their MAP as well as heart rate fluctuations were evaluated. Less hemodynamic fluctuations occurred in the low-dose remimazolam group compared to the high-dose remimazolam group. There were no significant differences in the remimazolam group compared to the group of patients induced with etomidate. This study shows promising signs for a useful alternative to patients in need of cardiac stability while reducing the side effects that come with the use of etomidate, such as pain at the injection site, nausea and vomiting, myoclonus, and adrenal suppression. To summarize our research, remimazolam is a promising anesthetic option due to its rapid onset and offset, making it useful for procedural and general anesthesia. It provides superior blood pressure stability compared to propofol and causes fewer side effects than etomidate. It is ideal for high-risk patients requiring stable blood pressure, such as the elderly or those with cardiovascular issues. It is not recommended in patients with severe liver impairment without careful dose adjustment, and its use in the pediatric population has not been established. When considering future research, more studies comparing remimazolam with other agents like dexmedetomidine or ketamine to expand its understanding of its safety profile would be of use. Research on its use in complex or long-duration surgeries, including neurosurgery and cardiac procedures, would be very beneficial, and investigating its potential use in the pediatric population to broaden its clinical applications should be studied. Cost-effectiveness studies in different healthcare settings to support a wider adoption would also be of use. And here are our references to refer to our studies mentioned. Thank you for your time. We hope this presentation aided in your understanding of remimazolam and increased your comfort level to administer this medication as a provider. Please fill out the post survey following our presentation. We really appreciate your time. Thank you so much.